So basically the talk is about whether we're going to do open surgery or MIS. And the question is MIS worth it? Is it better than conventional surgery? Is it safe? And are the benefits worth the extra mile? Why do we do newer procedures actually? It's because we are attracted to new things, because we want to impress our colleagues and also as a marketing gimmick. So that's all the reasons why we do new things. But sometimes we do it. Oh, I'm sorry, Vishal isn't there. Sometimes we do it because we genuinely believe it's better than the present techniques. So the main thing is to see whether we believe in MIS or we just say we don't believe in this. So I am here today to give you a balanced view, much to the contrary of what I normally do. The issues are these, and we'll go through all of them. We are short on time, so I'm going to say we are going to either give a thumbs up to MIS or a thumbs down, or we are going to give a yellow, which says that it's equal. Let's look at SCAR, because we are looking at all the indications, stroke excuses for doing an MIS instead of a conventional stroke open procedure. One of them is scars, and yes, the scars look smaller and better, and that's the scar for an open. But eventually, if you do look at this done by a Medtronic sextant thing, you have like 1.5, you have 1.5, you add all of them, it comes to 13.5 centimeters, which is almost the same as a midline scar, and it looks as if somebody's taken a gun and used the back for target practice. The other thing is, no one is really looking at the Indian backs, and Deepika Padukone tried, but she's been banned. So everybody else, the Indian women, The other thing which we learned in first MBBS from our seniors is that a 1 centimeter incision heals in the same time as a mile because it heals from side to side. So I think scar, well, if you go for that sort of thing, I would say it's not really a good reason. What about invasion? The inside invasion is exactly the same because you have to do the same job inside. If you don't do it, you're not doing the right thing. The decompression, discectomy, end plate preparation, cage, screws, all of it has to be the same. The difference, of course, is in the muscular envelope, and I grant that. In the open, there is definitely more soft tissue damage because you really have to go lateral, you have to retract it, you go much longer, and especially to put your pedicle screws, you have to go much more laterally and much more longer, and you do damage the vascularity of the soft tissue envelope. Whereas the MIS is that way better, but it's not really all that is cut out to be because there is a tearing of tissues at the screw insertion, and we just look at the x-rays or the images and put in the screws. We don't know what the hell they are damaging over there, the facet or whatever it is. And when you are doing other procedures, when you put the tubes, you actually burn and rip out the tissue downstairs. So I still concede that the MIS is more friendly and you would get a thumbs up for the MIS. What about bleeding? They say there's less bleeding. Well, bleeding depends on surgical technique, anesthesia and positioning. And the troublesome bleeding in spine surgery is the epidural bleeding. Yes, exposure related bleeding is going to be less in MIS, but if you encounter an epidural, you can bleed as much or more in an MIS than in an open. Still, overall, a thumbs up to MIS. Post-op pain, literature and proponents do suggest less post-op pain. In my experience, which is like a SF1, I feel there's absolutely no difference. It's because pain really comes from the deeper structures and the procedure is as invasive in the depth as it is as open as is MIS. And pain is highly personality and patient dependent. I've had patients with a 4-level open decompression who are running around the hospital post-op, and those with a 1-level microdiscectomy who stick to the bed for 5 days. Plus, pain is always you can modify or control with drugs. However, having said that, post-operative pain may be slightly better with MIS. I mean less pain. I didn't mean more. What about mobilization? That's another thing which MIS talks about. You can mobilize them the same day. But I think even the so-called open TLIF patients, we were mobilizing on the same day, same evening or the next morning. So I don't think that is another major factor. Again, patient personality and pain is very important in mobilizing patients rather than the procedure. Earlier discharges for MIS, you can kick out a patient from the ward whenever you want if you want to write a paper, and you can send them to a halfway house. And our Indian patients like to stay in the hospital for long, especially if the food is good. Many of them like to get away from their mother-in-laws and other things, so they tend to want to stay longer. So I don't think discharge times can really be a good indicator. Having said this, yes, there are no drains, tubes, etc. So in principle, you can discharge the MIS earlier. I would say equivocal. Few days here or there. In India, doesn't matter. Our hospital beds are pretty cheap. What about the cost? The MIS requires more expensive implants. This is because I use only the imported implants for this. I'm very uncomfortable using the Indian set because I think a lot depends on the way these implants are made. And therefore, you increase the cost of the implants This is a slightly older presentation, and the surgical time used to be more, but now my MIS takes less time than an open, so that point isn't there. And you need to buy retractor systems, you need to have navigation, blah, 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 all of that. So Indian implants are coming up, but there's still some time. You rely on infrastructure. If you don't have an excellent C-arm with great visualization or navigation or computer, and now robots for that matter, you take risks technically and you may land up in a huge soup. So if you want to do this in a small nursing home outside Andheri, or outside this hotel, then you're better off knowing how to do a so-called open TLIF where you don't require much of infrastructure. You also require well-trained technicians to take you through the procedure. You're really dependent on them. Radiation hazard to me is like the biggest issue if you don't have navigation, because you do require multiple shoots. We've had friends and other surgeons, other colleagues getting various types of cancers. So the radiation is one thing which truly, so there are two things which bother me about MIS TLIF. I'm going to come to the second one. And the last thing I want to do is, have fried eggs at the end of my life. So that's one thing down for MIS. The decompression, again, I think that it's a very limited decompression. We sort of approach one thing over there, and the opposite route, yes, you can do over the tops. And I know there are cases which, for instance, I would never do MIS decompression, but I've shown these cases to, I'm sure many of you all, but just to pick a name out of the audience, Arvind, and he says he can do it through the tube as well. So that I think is a lot to do with surgical technique, but sort of people who are comfortable with seeing everything may be more comfortable with open decompressions. So that's a downside, because technically to get a good decompression, which is the core surgery which you want to do, is more difficult with the MIS. Fusion is another thing which hugely bothers me. I think the graft quantity is much, much less when you do an MIS TLIF. The disc removal and end plate preparation is probably inferior, and we are used to seeing such rock solid fusions, which we don't see in MIS. And on the left is the sort of bone which you get through an MIS, and on the right is the sort of bone which you get through a so-called open midline procedure, and then the amount of bone is much less. So you may need to harvest bone graft, which is a 7th incision, to a guy who you've said no scars, or you may use BMP or substitutes which add to the cost, or you can just ignore it and say, I'm just going to put my screws and fuck the X-ray. So I think fusions is not as good in MIS. Applicability, the indications where a MIS TLIF are less. I won't say few, this is an older one. And many of the patients who we see being treated with MIS in the presentation from abroad are those who we wouldn't operate in the first place, because our Indian patients come with very advanced pathology like severe stenosis, large discs, etc. For multi-levels as well, it's more difficult, and I think it's like holding your ear this way. Yes, of course it can be done, but I just feel it's easier to open and do both the levels through one incision. High-grade spondylolisthesis, I am not comfortable. Again, the stars of MIS are comfortable doing this, and more power to them, but I wouldn't do one of this. So the applicability for the MIS TLIF is little less. You need to select your curve, your patient. What about the learning curve? It's pretty steep, and if you make errors, it's the patients who suffer. So if we have like, ASSI has 800 members and each one has to learn on 100 patients, that's 80,000 patients who are going to suffer because we are trying to learn the MIS TLIF. So you need to do at least 50 open before you're well oriented to doing the MIS TLIF. Whereas the open surgery has stood the test of time, and we've been doing it over years. So the open TLIF is pretty good. So now I've got to rush through. The complications are about the same. Forget the literature. I know, because I've run out of time. But the literature does not show MI TLIF to be superior. At worst, it is equivalent. And therefore, the balanced view is for the seniors like my friend Abhay, don't really bother to learn it. It has no advantage, and you get good results with what you do. For the youngsters like Vishal, who didn't turn up, it's a great marketing tool. Learn the craft, select your cases, push the boundaries, and that's what these guys are all doing. And for the next generation, which is most of you sitting over there, you have to learn it because it is the way of the future. And MIS, minimal invasive surgery, is very much here to stay. So there are two ways to do a TLIF, midline and lateral. You can call them open or MIS. Select the one which is right for the patient, the surgeon, and the setup. Don't compromise the basic aim of the procedure just for the technique, because you need to get the result in the patient. And the issues are 3: bone graft, radiation hazard, and learning curve. Thank you.